Hello, and welcome to our symposium. This is the development and evaluation of virtual adaptations of evidence-based interventions for autism spectrum disorder and Fragile X syndrome. I am the chair, Rebecca Shaffer from Cincinnati Children's Hospital, and our wonderful discussant will be wrapping us up at the end, Judy Reaven from JFK Partners and the University of Colorado Health Sciences Center. Here are the presentations for our symposium. First, we will have Vivian presenting Adapting the Secret Agent Society, Operation Regulation Intervention to Remote Delivery in Response to COVID-19. Next, we will have Amy presenting Family and Caregiver Characteristics Contribute to Caregiver Uptake of Strategies and Growth in Child Spoken Language in a Remote Delivered Parent Implemented Language Intervention in Fragile X Syndrome. Third, we will have Jasper presenting Peers for Adolescents via Telehealth Delivery, Thumbs Up or Thumbs Down. And finally, myself, Rebecca, will be presenting Virtual Emotion Regulation Treatment for Children with ASD, an intensive group parent-assisted pilot program.
Hi, I'm Dr. Vivian Lee. I'm pleased to present findings from a project titled Adapting the Secret Agent Society, Operation Regulation to Remote Delivery in Response to COVID-19. This is research conducted with my postdoctoral supervisor, Dr. Jonathan Weiss, and his lab at York University. Autistic children and youth carry a particularly high burden of emotional and mental health challenges. About 40 to 70% of children on the spectrum meet clinical levels of emotional and mental health difficulties. You can imagine that the abrupt changes due to the pandemic have exacerbated some of these challenges. Difficulties are often highly interrelated, and there are suggestions that an underlying transdiagnostic difficulties with emotion regulation may be an important domain or mechanism to target in treatment and interventions. Transdiagnostic cognitive behavior therapy is a common approach to addressing multiple kinds of mental health problems in youth, including those on the spectrum. One such program is the Secret Agent Society Operation Regulation. It's an in-person SPY-themed manualized TCPT program where parent-child dyads participate in individual sessions and learn emotion regulation and social skills. In response to lockdown measures due to COVID-19, our lab took this opportunity to adapt the program for remote delivery. We had two objectives in this research. We used an explanatory mixed methods approach to, one, explore the acceptability, feasibility, and clinical utility of the adapted online version of the program within the context of a pandemic, and two, to explore the strengths and challenges of a remote emotion regulation program for autistic children. So what did we do? We, in March, prior to the lockdown measures, we had 11 child parent dyads who were anticipating in-person sessions. Average age of each child was 9.86 years. All children were verbal, confirmed diagnosis of autism, and had an IQ of greater than 79. We were able to administer pre-programmed measures that included those measuring internalizing, externalizing challenges and behaviors, as well as emotion regulation and social skills. After lockdown measures were in place, between April and May 2020, we trained therapists and adapted the intervention for online delivery. For example, with our clinical team, we were able to discuss how to onboard parents for online delivery. As a team, we were able to set best practice considerations for participant confidentiality, client privacy, how to handle challenging behaviors, and how to adapt and personalize delivery for each child. In June, we were ready to deliver the program online, and so we started onboarding parents by introducing them and orienting them to the technology involved in each session. We provided 10 weekly online sessions, 30 minutes to 1 hour each. We administered post-program measures after the parent and child had finished the program. And importantly, we conducted interviews with each parent and therapist after the completion of all sessions. So what did we find? Using the implementation accessibility scale, which is a 7-item lab developed measure that were administered to parents about the intervention's acceptability. Respondents were asked to describe their experiences receiving the intervention on a 5-point Likert scale. Overall, majority of the parents reported the program being acceptable or highly acceptable across the 7 items on the scale. Parents also completed the program satisfaction questionnaire at the end of the intervention, and this was used to assess their views on the appropriateness and the effectiveness of the program for their child. Across the items, between 73 to 100% of the parents either rated high or very high satisfaction for the program. In terms of child outcomes, we found no significant change in internalizing and externalizing scores from pre and post program participation. But we did find significant difference in parent-reported emotion regulation and social skills. In terms of our qualitative findings from our interviews, we used a thematic analysis and found 4 distinct themes. First, parents and therapists talked about behavioral management needs during the pandemic. The reports of experiences were variable. Some children were doing better and others were not. But overall, parents still reported persistent challenges with emotion regulation and social skills in their child. The second theme that we found was around the process of onboarding. Parents noted being very hesitant with the new online remote delivery of the program because their expectation was that the program would be in person. But they did find that the onboarding process that we provided was very helpful in terms of orienting them to the technology and setup for each session. Therapists noted that they took this opportunity during the onboarding process to build rapport with the families outside of the therapy context. The third theme that we found was around the process of program delivery. Parents were first impressed that therapists were able to build and maintain rapport with children via an online platform. And although they reported very high satisfaction with the adaptive program delivery, there were some challenges, including when emotions ran high during frustrating tasks. Parents reported that some of their children had difficulties sitting in front of the camera for extended periods of time. They had difficulties engaging in some of the tasks, and parents had to sit with them in order to complete the sessions. In response, therapists spoke to the importance of individualized sessions in order to de-escalate situations that might lead to emotional outbursts, especially when they were not in the same room as the child. Therapists noted that it was important to have a parent as a co-facilitator in order to complete the session. And it was sometimes beneficial, but often it was required in these situations. The fourth theme that we found was around the evaluation of the program utility. So despite having behavioral challenges, sometimes interfering with program delivery, parents overall noted that they and their children learned a common emotional language. Remember the significant increase in the parent-reported measures of emotion regulation and social skills. And here, the interpretation from the interviews suggests that it may be because parents observed better management of emotional outbursts using skills learned from the program. Therapists overall enjoyed delivering the program, but wondered about the effectiveness of the program due to their modifications and deviations during the manual in order to maintain rapport with the child, de-escalate challenging behaviors, and to individualize the program for online use. So overall, parents found the adaptive program feasible and acceptable. We found high overall program satisfaction ratings by parents who participated. But of course, there's a number of limitations. This program and the way that we've delivered it online may not be applicable to autistic children with complex needs. Remember, the children in our program were verbal and had an above average IQ. Families in our program had access to high-speed internet and technology, and not all families may have that. And even though we had limited difficulties due to high-speed internet and technology use during the program, these were some limitations that we have to consider. Also with our research, we had no control group, and the parents who participated were convenient sample of participants. But lessons learned are that this program may not be for every child, although it worked for the kids in our program. Some parents noted that the program content was helpful, but the delivery online was not, because their child was shy, had attentional challenges, and could not sit in front of the computer for an extended amount of time. Parents noted having shorter sessions would be ideal. So even though we had some sessions that were 30 minutes long, they felt like breaking them up into multiple shorter sessions across the week might be more helpful. And they also noted, we also noted that there's importance of catering to individual interests. So taking into account special interests and topics and specific individual needs within the program to really support kids in their emotion regulation and social skills building. And that concludes my talk. Thank you so much to the Developmental Disabilities and Mental Health Lab at York University and our families. And of course, thank you to our funders.
Hello, my name is Amy, and today I will be talking about how family and caregiver characteristics contribute to caregiver uptake of strategies and growth in child spoken language in the parent-implemented language intervention in Fragile X syndrome. Fragile X syndrome is a multi-generational group of genetic conditions. In youth with the full mutation, it is the leading cause of intellectual disability. It is also characterized by delays across multiple domains of language, with overall delays being more severe in males. Because Fragile X syndrome is an X-linked condition, biological mothers also have a unique phenotype. Mothers can either be carriers of the premutation or have the full mutation and are more likely to experience symptoms of anxiety and depression as well as parenting stress than the general public. In light of these phenotypic profiles, the number of opportunities that children have for learning and practicing language might be limited. So we want to increase these opportunities for learning and practicing language, and one way to do that is through parent-implemented intervention. In this model, clinicians work directly with the parent through one-on-one sessions to teach specific support strategies that the parent can use with their child. Then, when the parent is interacting with their child, the clinician provides coaching to the parent in real time. Importantly, the true value of this intervention approach happens when the clinician is not there. Instead, parents take on the role of the clinician in their daily lives, thereby increasing the dose of treatment the child may receive. And because parents can implement the language support strategies during different types of interactions throughout their day, the likelihood of generalization of skills that the child is learning improves. Recently, our team has utilized parent-implemented language intervention, or PILI, to support youth language outcomes beyond early intervention. We did this by teaching parents a set of tools that can be used during a shared storytelling activity. During this activity, parents provided enhanced verbal language input, and the youth are encouraged to participate in developmentally appropriate language learning activities. Our intervention has been validated across multiple study designs, first as a multiple baseline design, then as a waitlist controlled study where half of the participating families received PILI and half received treatment as usual, and finally in a trial combining PILI with a medication where all of the families received PILI regardless of active drug or placebo. A notable feature of our lab's approach to parent-implemented language interventions is the adoption of a telehealth model for delivery. Using distance technology meant we could reduce the burden of travel on families, complete the intervention in an environment that is familiar to the child, and we could work within the confines of the family schedule more. We provided each family with all of the materials needed to participate in the intervention, and parents connected with the clinician via secure video teleconferencing software. The intervention started with 2 parent education sessions where we introduced the specific language support strategies. This was followed by 12 weeks of intervention sessions, during which the following happened once a week: a live bug in the ear coaching session where the clinician observes the parent and youth interacting and provides guidance and feedback to the parent via an earpiece; a homework session where the parent records themselves using the strategies with their child and sends to the clinician for review; a feedback session where the clinician and parent discuss the homework and strategy used during the week; and finally a data collection session where the parent can implement the feedback from the clinician. The time commitment for each parent was 3 hours of initial training, followed by 2 hours of sessions with the clinician weekly. As I mentioned, the context for the intervention was shared storytelling, so we used wordless picture books loaded onto an iPad. The books had very little text, so the pictures served as the conversational topic for the pair. The specific language support strategies that the parents learned were modeling story-related talking, or modeling language that the child can use to talk about the story, asking open-ended WH questions, expanding child utterances or adding a word or two to what the child says, and using intonation prompts or fill in the blanks. Data that we will be talking about today were collected from the waitlist control and the trial combined with medication PLE studies. Between these two studies, we had 47 parent-child dyads participate. In both studies, the youth were between the ages of 10 and 17 years old. The waitlist control study included 19 sons and their biological mother. 9 of these dyads received treatment as usual, and 10 received PLE. In the PLE plus drug combination study, 26 sons and 2 daughters participated. Parents included 25 biological mothers, 2 adoptive mothers, and 1 adoptive father. 16 of these dyads in this study received PLE and placebo, and 12 received PLE plus drug, which was lovastatin. For change in youth spoken language measures, all 3 PLE groups had significant differences in youth measures when compared to the no PLE group, and there were no significant differences in youth spoken language measures between the 3 groups that received PLE. For the parents, all of the groups that received PLE significantly improved in their use of the targeted language support strategies compared to those that did not receive PLE, but it is notable to point out that there were some significant differences in the uptake of strategy use across the 3 PLE groups, which warranted further investigation. Given that we know that there is stress associated with parenting a child with developmental disabilities and that biological mothers of a child with Fragile X syndrome are more likely to experience symptoms of depression and anxiety, as well as the intensity of the study design, it was warranted to further investigate the relationship between parent factors and the uptake of language support strategies. To gather information on parental well-being, parents fill out questionnaires prior to beginning the intervention. These questionnaires included the Parenting Stress Index, which was a questionnaire that scores across 3 domains of parenting stress, including parental distress, parent-child dysfunctional interaction, and difficult child, as well as a measure of total parenting stress. Parents also filled out the symptom checklist, which measured psychological problems and symptoms of psychopathology. Scores from the anxiety and depression domains were included in this study. And finally, parents filled out the Parenting Sense of Competence Scale, which is a self-report questionnaire measuring parent efficacy and competence. Our specific aims for today are to look at how parent uptake of intervention strategies would be impacted by higher symptoms of depression and anxiety, increased levels of parenting stress, and overall feelings of parenting competence. We also wanted to explore any carryover effects this would have on child spoken language outcomes. For the first strategy of overall parent story-related talking, for the parents who did not receive PLE, the change in strategy use was significantly related to more child-driven factors. Namely, it was negatively related to the difficult child domain on the PSI. For the parents who did receive PLE, their change in overall story-related talking use was driven by parent factors. Story-related talking use was negatively related to symptoms of depression and positively related to parents' sense of competence. For the other 3 strategies, we see that for parents who did not receive PLE, the change in strategy use was again driven by child factors. Specifically, the use of open-ended questions was negatively related to the difficult child domain and total parenting stress on the PSI. For parents who received PLE, the change in parent strategy use was again driven by parent factors. Here, use of expansions and intonation prompts were negatively related to symptoms of depression, with intonation prompts also being negatively related to parental distress domain and total parenting stress on the PSI. Also, the use of expansions and intonation prompts were positively related to the parent sense of competence. There were some unexpected relationships within specific groups. In the PLE plus placebo group, parent uptake of strategies was driven by dyadic interaction factors, but opposite to the direction that we hypothesized. The parents' overall use of story-related talking and use of open-ended questions were positively related to the parent-child dysfunctional interaction domain and the total parenting stress on the PSI. One reason for this might be that more challenging dyadic interactions require more scaffolding from the parent in terms of modeling story-related talking and asking more questions in order to encourage their child to participate in the activity. Also interesting was that anxiety was not related to the uptake of strategy use across any of the groups. For the carryover effects on child outcomes, we saw that the changes in child spoken language followed similar patterns of parent uptake of strategies. For the youth who did not participate in PLE, changes to their story-related talking and number of different words was related to the difficult child domain and total parenting stress on the PSI. For the youth who participated in PLE, we saw the following changes. Story-related talking was negatively related to parents' symptoms of depression. Number of different words used was positively related to parents' sense of competence. Number of different words used was also negatively related to parents' symptoms of depression, as well as parental stress and difficult child domains on the PSI, with the latter being an added relationship that we didn't observe in the parent uptake of strategies. Our findings suggest that measures of parental well-being influence the outcomes of parent-implemented interventions, affecting not only the uptake of targeted language support strategies, but also aspects of child treatment gains. More work is needed to further differentiate what family factors might be most critical to the efficacy of parent-implemented interventions, and ultimately how these factors should be addressed within the interventions. Thank you first and foremost to the amazing families that participated in the studies, to the study PIs and project staff, and to our funding source.
Hello, everyone. I'm Dr. Jasper Estabillo, a postdoctoral fellow at the UCLA Peers Clinic, and today I'll be presenting on Peers for Adolescents via telehealth delivery, thumbs up or thumbs down. An overview of today's agenda, we'll start off with a background of peers, move into previous research and a pilot on telehealth. We'll discuss the present study, discussing outcomes, and then wrapping things up with conclusions. One thing to note is that I will be utilizing identity first language throughout this talk in accordance with self-advocate and stakeholder preferences. Starting things off with a little bit of a background. So Peers is an evidence-based social skills program with groups for teens, which I'll be focusing on for today, as well as young adults and preschoolers. And we also have additional groups that are in the research phase. Peers is manualized and widely disseminated. It's currently translated into over a dozen different languages and used in over 85 countries worldwide. The focus of Peers is to teach ecologically valid social skills that target friendship making and managing conflict and rejection. And an important thing to note about Peers is that it is parent or caregiver assisted. And so this really facilitates generalization of treatment gains outside of the treatment setting, as well as long-term maintenance of these outcomes. Researchers have generally found improvements in social skills, social engagement, social skills knowledge, and decreases in autism symptoms and mannerisms. Our colleagues at the Center for Autism and Related Disorders and a small telehealth pilot found similar treatment outcomes from their telehealth group with in-person delivery. So we saw decreases on the SSIS problem behaviors, increased SSIS social skills, and improvements on the SRS social responsiveness. The goals of the present study were to examine the efficacy of Peers for Adolescents via telehealth delivery and comparing outcomes between our in-person and telehealth groups. To be included in the current study, we wanted teens that were 12 to 17 years old with an autism diagnosis and or clinically elevated autism symptoms on the SRS-2. And our groups were comprised of our telehealth and in-person groups. So to start, our telehealth group included 26 teens, about 13 and a half years old. 65% of the group were male and about 58% were white. Our in-person comparison group were 212 teens, about 14 years old, 73% of which were male and 59% white. There were no significant differences in demographics between our telehealth and in-person groups. Outcomes were measured at baseline and at post-intervention with the following measures. So the SRS, TASC, SSIS, and QSQ, both teen and parent report. I did want to highlight some differences between in-person and telehealth structure. So our groups are structured with 16 weeks of 90-minute sessions. We have concurrent teen and parent groups. In telehealth, our adaptation is that everything is done remotely on Zoom. The content, which is the Peers for Adolescence Treatment Manual, is presented by a group leader who uses a whiteboard to facilitate Socratic questioning and to elicit responses to create the rules and the steps. Our telehealth modification is that we, instead of the whiteboard, we use the PowerPoint slides to share that content. And we also include some modified steps for online social skills. So different lessons like starting and joining conversations and how to have online get-togethers. Our social skills are taught via role plays in person. These are conducted with our wonderful behavioral coaches. And on telehealth, we have these models for appropriate and inappropriate skills in these video role plays. Our teams also have the opportunity to practice, get some live coaching and feedback through behavioral rehearsals. In person, they do this in small groups. And over telehealth, they do this in their virtual breakout groups. So they're broken up into smaller groups and they practice in these virtual breakout sessions. We assign homework each week. And in our telehealth groups, we've added additional in-group get-togethers to further practice these online social skills. To promote engagement and interaction in our telehealth groups, we really encourage our teens to give a lot of verbal praise, unmuting themselves and giving themselves and each other lots of kudos. We also encourage lots of nonverbals, so thumbs up, thumbs down, using those Zoom reactions, and typing into the chat feature if appropriate. So getting into our telehealth results, when it comes to efficacy, we saw significant improvements from pre to post in social responsiveness. At post, our teens are moving from the moderate to the mild range, which is very exciting. And we also saw significant improvements in social skills knowledge. So at post, our teens are almost at the ceiling score, which is 30 on this measure. We saw significant improvements in general social skills. Our teens at post moved from below average to the average range, and we saw a significant decrease on problem behaviors. So although our teens remained in the above average range on this measure, their standard scores were actually about a little bit over half a standard deviation in decreases, which is very exciting to see. When it comes to social engagement, as measured by the number of get-togethers that our teens participated in the previous months, so this is both hosted and invited, so their total get-togethers, our teens reported a significant increase, as well as their parents reported a significant increase in social engagement in the previous month. Very, very exciting to see efficacy results for telehealth. When comparing our telehealth with in-person delivery, we saw no significant differences on any outcome across treatment modality. So no differences between telehealth and in-person groups on social responsiveness. This looks like one line, but I promise you it is two. Our results are just that similar between our telehealth and in-person groups. Same thing for social skills knowledge. Again, this looks like one line, but I promise you it's two. The telehealth and in-person groups are just that similar in outcomes. No significant differences in general social skills outcomes, problem behaviors, or our social engagement. So teen report of get-togethers as well as parent report. So in all, no significant differences between our telehealth and in-person groups. In summary, telehealth delivery results in significant improvements in social responsiveness, social skills knowledge, general social skills, problem behaviors, as well as social engagement. And our outcomes are comparable with in-person and telehealth delivery, which is very exciting to see. So in conclusion, when it comes to telehealth delivery, we wholeheartedly give it a thumbs up. So Peers for Adolescence via telehealth delivery is a very promising method to teach autistic teens social skills and improving outcomes. This is very important in our current climate with remote learning and social distancing, where our teens have limited opportunities to interact with peers and to further develop some friendships and relationships. Telehealth delivery is not only efficacious, but results in similar outcomes to in-person instruction, which is very, very promising. This really highlights the benefits of telehealth instruction beyond our current COVID-19 pandemic. I can say for our own UCLA Peers Clinic, we've been able to double our census from 5 to 10 groups per week, and we've been able to expand our reach and accessibility to families outside of Los Angeles County, which is very exciting. Telehealth, as I'm sure you've experienced or have knowledge of, is not without its limitations. And so some of which include having accessibility to reliable technology and internet sources, having a private space to participate in our social skills groups. And we also have some missing data, but we are working on that with our ongoing telehealth cohorts. All this to say that we have established a need for continued research on telehealth to further enhance its efficacy and to continue to study its effectiveness. Given all these promising results, I can certainly say that we are going to continue to research this and further refine these groups so that way we can improve outcomes for our autistic teens. To wrap things up, I want to give a huge thank you to our wonderful peers families and our incredible team for navigating this transition to telehealth. I'd love to thank my co-authors. And lastly, I'd like to thank you, our audience, for your interest and attention during this talk and our symposium. I look forward to discussing further during our Q&A session. And I look forward to your questions then. Thank you very much.
Welcome. I'm going to be presenting about a virtual emotion regulation treatment for children with ASD in an intensive group caregiver-assisted pilot program. My name is Rebecca Shaffer. I'm a clinical psychologist and associate professor of pediatrics at Cincinnati Children's Hospital, and these are my collaborators on this project over here. This research was supported by the Place Outcomes Award at Cincinnati Children's Hospital, and my conflicts of interest include that I am an author of Regulating Together and I receive compensation for trainings related to the curriculum. So first, let's talk about Regulating Together and what the intervention looks like. It's an emotion dysregulation treatment for ASD that takes place in a group treatment setting in order to really address the dysregulation that occurs in social settings. It also allows us to treat more children at once. It's an intensive model, 90 minutes, twice a week for 5 weeks. And there is a caregiver-assisted component with direct instructions, support, and normalizing of caregiver experiences. So here's an overview of the curriculum, including the child material, the adolescent material, and the caregiver topics. And this is a nice visual of all of the components that go into this treatment model. So we were in the midst of a within subject study design when COVID hit. So we had a 5-week control period for each child, a 5-week treatment period, and then a 5-week follow-up and 10-week follow-up. And these were our outcome measures. We collected emotion dysregulation inventory reactivity, the brief emotion regulation index, the flexibility total score on the flexibility scale, and then the teen and children rate the amount that they've learned and how they feel in each session, and the caregivers rate satisfaction at the end of. So I'm going to talk about the virtual version now. In March of 2020, we discontinued our in-person groups and switched to a virtual format that began in May. We had 2 formats, an 8 to 12-year-old that was a caregiver live group and a caregiver-assisted video session for children. The 13 to 18-year-olds had a live caregiver group and a live adolescent group. All visits occurred virtually via Zoom, and we had the videos for the 8 to 12-year-olds on Play Pause It. So inclusion criteria for the trial, they had to have functional communication, which was really verbal with use of sentences. You can think of it as appropriate for a Mod 3 ADOS or higher. They had to be safe in a group setting, but with virtual, that was no longer a concern. They were separated and not having to interact within the group. IQ abilities above 65 standard score, emotion dysregulation as indicated by these features. Previously, they had to be located in the Cincinnati area, but we were able to expand recruitment nationally, and they had to have a confirmed diagnosis of ASD via the ADOS. For the virtual version, we did take ADOS and IQ scores per history. So let's talk about the child group. There was a 50-minute live caregiver group, same as in-person caregiver group, so no changes in regard to curriculum. We did have additional check-ins about how the video viewing was going and how their child was doing with that format. The children joined for the last 10 minutes of the caregiver group, and they practiced relaxation together, and they discussed a skill that they had learned in the video as a group. The child videos were uploaded to Play Pause It. They were facilitated with caregivers with pauses to discuss or complete activities. The children answered questions about how much they learned at the end of each video, and completion was tracked as well as amount of time viewing the video. And then the caregivers and child were all sent workbooks. And this included all handouts and activities that we would have given out in person. And this was mailed to families prior to the start of the group. So here are some results from our pilot. We had 13 participants in the child group. One dropped out during the control period. We had 100% retention during treatment though. 92% attendance ratings, which is pretty good and actually a little bit better than our in-person attendance rates. 61.5% were male, and this is actually less than our in-person rate. So we were able to recruit more girls as part of the virtual version than we're typically able to. Average age was about 10.2. The children rated how much they learned, and they gave ratings between 3.5 and 4.5 on a 5-point Likert scale for every single session. So they were rating fairly high amounts of learning. They also rated their emotions on a 5-point scale that we use as part of the curriculum. They consistently rated themselves between a 1 and a 2, which just lets us know that they weren't getting super frustrated with the material or with the format. Caregivers rated that they were satisfied or highly satisfied at the end of treatment. And here are some results, some t-scores. So you'll see in the first column the t-values, the second column the p-values. So this first set of values are from our control period, so screen to end of control. So you'll see no changes, and in fact, not even close to changes on reactivity during that control period. Then we see treatment start to treatment end, and we see some nice changes across all three measures that are statistically significant. And then those changes are maintained and they continue to grow in terms of amount of changes during the 5-week post and the 10-week post. The only one that we see a little bit of a dip for the kids is the flexibility score. Was still statistically significant, but not as significant as we see at other time points at that 5-week post. And these results are very similar to our in-person outcome scores. So now let's talk about the teen virtual version. So very similar to the child caregiver groups, there were about 5 to 8 caregivers, same curriculum as we offered in person. They had workbooks mailed to them. We decreased to 50 minutes. And we asked the caregivers to provide rewards for the teens at the end of each group and stay close during the teen group so they could provide assistance if needed. The teen groups were live, same curriculum as in person. We presented it via PowerPoint for them to follow along. Again, 60 minutes. We removed the break that teens got in the middle. They had the same leader as the caregiver group, and the workbooks were mailed beforehand to them. So we had 15 participants. 5 have completed at this time. 9 are actually active as I do this video. They'll be done tomorrow. We have had 1 teen drop out during the treatment phase, but otherwise we've had everyone stay in the study. The mean age is 15.5, and it was about 81.3% male, which is pretty similar to our in-person rates. Teens rated them that they learned the most during sessions 1, 4, and 5, which were relaxation, distress tolerance, and problem sizes and thinking patterns. They consistently rated that they were a 1 to 2 on a 5-point scale across all sessions. And caregivers rated that they were satisfied or highly satisfied. All right, I'm just going to show you the means for the virtual teen version results. So this is the EDI reactivity and dysphoria. Here is the clinical cutoff score. So we see this nice improvement. Lower scores are better. So even at 5 weeks post-treatment, we're seeing a really nice improvement that shows that they're no longer in the clinically significant range as a mean. Same thing for dysphoria. We see in the clinically significant range at that end of control period, and then we see some really nice improvement after that. We also have the flexibility total. This does not have a cutoff score, but we do see a nice decrease from the beginning of control, end of control, treatment, post-treatment, and then post-treatment. We do see a little bit of regression at the 5-week post for flexibility, but we see it go back down nicely. And then finally on the brief emotion regulation index, this is the clinically significant cutoff score here, and we do see this really nice decrease in scores. So lessons learned, the benefits of virtual was that we were able to do national recruitment. There was less of a concern for safety in the room. It was feasible for families. Only one clinician was needed. Baseline and follow-up visits were very easy to schedule because they happened virtually, and measures were entered directly into REDCap as the families completed them virtually. We had more teen involvement with the chat option, so they didn't have to talk out loud all the time. And the workbooks were a really nice touch, something that we'll probably continue to do even in person for families. Challenges were that the length of the session was decreased, which means we just didn't have as much time to complete material. We lost break time for teens. There was less caregiver and teen interaction. It was a greater time commitment, an hour for each of them instead of an hour and a half total. We weren't able to complete heart rate variability, and performance-based testing, which are core components of our usual outcome measure assessment. It required ability to focus on a computer and really good internet access, and there was less opportunity for in vivo instruction. In summary, they're both feasible and acceptable. Our outcomes are similar to our in-person results. We saw improvements across the board for both children and teens, and families reported really high satisfaction. Next steps include adapting the virtual curriculum based on the feedback that we receive and the experience of the clinician, a larger trial of each version, and a potential trial of in-person versus virtual to examine the differences between the two. We also really want to explore the caregiver-assisted videos as a separate intervention with caregiver instruction also in video format. Just a quick thank you to all of my collaborators, the clinicians who have worked on these studies, and a huge thank you to all of the families who have participated in our program over the past 6 years. Thank you so much.
Hi, everybody. My name is Judy Reaven, and I'm excited and honored to be able to talk about these 4 wonderful presentations as part of the symposium on virtual adaptations of evidence-based interventions. So I wanted to talk about adaptation and start our conversation and adaptation in the before times. Because the truth is, we've been doing a lot of adaptation prior to the pandemic. And the reason we've been doing adaptations is because evidence-based practice is hard to implement in real world settings. It's hard to implement because there aren't often enough providers who are able to do an intervention. That particular evidence-based practice may not fit in the context of the community setting, nor may it be feasible. And there may not be time to devote to the kind of training that's required to deliver an evidence-based practice in its truest form. So the goal this whole time has always been to how do we adapt interventions so that they do fit in community settings and they are ultimately sustainable. As we think about adaptation, though, we have to be thinking about treatment fidelity and trying to balance those two things. The point here is to be thinking about the kinds of adaptations we make. We want to consider them to be fidelity consistent so that they're consistent with the true intent of an intervention, maybe increasing the length of an intervention, versus fidelity inconsistent adaptations, ones that really might take away from the original intent. So maybe eliminating core components. Those are the ones we want to try to avoid. And then finally, we want to be careful about being too rigid in our delivery of fidelity so that in some ways it might prevent the possibility that an adaptation could actually improve outcome. So those are some things we want to consider here. As we move towards the 4 presentations that did talk about adaptation and in this case, during a pandemic. So there are a number of strengths across these lovely presentations. Here are some of them. I really appreciated the use of mixed methods in the Secret Asian Society program, where we're really not just looking at the kind of quantitative outcomes, but we are looking at implementation acceptability as well as the program satisfaction. That was something that Regulating Together looked at as well, was kind of the consumer satisfaction. A number of the programs provided materials, even including laptops and other technology, so that families would be prepared to do the virtual delivery. There's the live coaching element of the Peely project. I appreciated Jasper being able to give us a side-by-side comparison of the PEERS project so that we could really see the adaptations between an in-person versus virtual delivery, and that many of the programs and presentations talked about impressive results that were doing a comparison between their in-person results versus their virtual delivery, which appeared to be equivalent even with these small n's. Some of the surprising benefits of being able to do a virtual delivery have been recruitment. In some cases, you can have a national recruitment. There was the opportunity to increase females in a way that maybe you couldn't do in an in-person group. Of course, attendance can be improved. Families don't have the burden of travel. Rebecca talked about the ability to have safety as less of a concern in the group. You don't have to screen for that because the kids are not together in a group. And that a number of the presentations also talked about this potential for generalization of skills because of the interventions happening in the family's natural environment. There are also challenges, though, thinking about virtual delivery. In some cases, there can be a decreased dosage of the intervention, less opportunity to do the things that you would do in an in-person context. Some of that can be less opportunity for direct instruction or even individualized instruction. In some cases, less opportunity for parents and kids to work together. There is the potential moving forward in other contexts for connectivity issues, especially families that might come from low-income circumstances. And this idea that virtual delivery may not be for everyone. And I want to say more about that in a minute. But first, I want to talk about give you some food for thought and sharing some ideas about an adaptation model. So that as we're thinking about adaptation, one of the things that I think might be helpful, that I find helpful, and maybe you all might find helpful, is to have a particular model that can guide the kinds of changes that you make as you're considering adaptation, whether it's for a pandemic or not. So the CDC has a traffic light model that reviews green light, yellow light, and red light adaptations. Green light are the kinds of adaptations that are okay to do, that don't impact the delivery of the evidence-based practice, all the way through to red light kinds of adaptations that you want to try to avoid because they really might compromise the effectiveness. David Chambers and colleagues talks about the adaptome, which is this idea of just continuing the discussion of intervention adaptation. And I really like this idea that adaptation happens all the time and that's natural and we don't have to be afraid of it. Sometimes adaptation can lead to outcomes that are even better than what we might have imagined in the original program. Other times though, if we drift too much, we have to be careful about decreasing effectiveness, and that the sustainability, and I want to circle back to this idea, the point of doing adaptation is so that our evidence-based practices can be sustained over time. Finally, I'm going to leave you with some thoughts that at least I want to be thinking about in my own work, and maybe you will too, which is who are the folks that are most appropriate for telehealth? Some of the kids might respond very well, but some may not. And I think some of our future work needs to help us identify who is a good fit and who is not. This idea of generalization has been raised, and I think it's an important one. And with the idea that virtual delivery really has the potential to improve generalization, but I think it would be great to try to see if we can measure that and really understand if that is something that in fact can happen with a virtual delivery. Some of the presentations talked on this a bit, which is this idea of what are we losing when we do a virtual delivery? Are we losing a therapeutic alliance? Are we losing opportunities to connect in a way that we're not even sure that we're missing because we're doing something virtual that in person just happens so naturally that you may not even be aware of? And kind of this final thought of, well, when would you not do telehealth? So there's a lot of great excitement, and certainly in this last year, of how nice telehealth approaches have worked in virtual delivery. But moving forward, and as things start to open up, I think we all want to be thinking about, are there circumstances, are there populations, are there target problems that may not be most amenable to a telehealth kind of delivery? So those are just some quick considerations. Looking forward to the Q&A, and again, thank you very much.